thank you, and I want to express my appreciation to all the people who did the real hard work in organizing this conference. I'm going to be discussing the neuropsychiatric aspects of Parkinson's disease, and what I hope to do, there's several things that I hope to do over the next half hour. One is that I hope to pick up on some of the themes that were in the morning's presentations and perhaps demonstrate how these different aspects of psychiatric symptomatology and the approach to elderly patients can be, how this can be applied to a specific condition, a complex condition such as Parkinson's disease. And then what I hope will be a smooth segue into a consideration of a specific case, so that we can then analyze that case from multiple perspectives to see again how these different themes can be brought together with either a well, we're going to do it multidisciplinary because we're going to do it first multidisciplinary because we'll have our panels make little presentations in sequence, and then it'll be interdisciplinary because we'll all be doing it at the same time. Okay, so if you could turn on the projector. Right. Okay. Well, it worked before. Anyway, while we work on that, so we're going to be focusing on the neuropsychiatric aspects of Parkinson's disease, and I thought it might be worth a few moments of our time just to discuss what we mean by Parkinson's disease. We first start with a definition of Parkinsonism as a syndrome. Okay, and as a syndrome, it has three cardinal features. Those are rigidity and tremor at rest and bradykinesia. When you have all of those together, you call it Parkinsonism. Sometimes people will add a fourth symptom of a gait disturbance because that is so common in patients who have Parkinsonism. Parkinsonism itself is, are we making progress here? All right. When we're talking about Parkinsonism as a syndrome, therefore, it may have many different causes. And depending upon what the cause is, you will see different manifestations of these symptoms. The most common cause of Parkinsonism in the elderly is idiopathic Parkinson's disease. Idiopathic, we don't know what causes it, although there may be a very strong genetic component, but it seems to be one of the degenerative neurologic diseases. We can also see Parkinsonism secondary to a variety of drugs, toxins, cerebrovascular disease, hydrocephalus, and many other secondary insults to the central nervous system. In all of these other causes, there's the common thread of damage to certain parts of the brain, deep in the brain stem and deep within the cerebral hemispheres. And these parts of the brain are very important in the control of movements, and as we will see, also in the control of different kinds of thought processes and emotions. One way in which one distinguishes these secondary causes of Parkinson's disease from idiopathic Parkinson's disease is that in these secondary causes, there are going to be variable neurologic signs and symptoms associated with that. So for example, if somebody has Parkinsonism as the result of cerebrovascular disease, that person is also likely to have some mild weakness at least, or some asymmetries in their reflexes, other clues to the presence of cerebrovascular disease. Also, in many of these secondary causes is much less in the way of tremor than there is in the idiopathic Parkinson's disease. One also can see Parkinsonism. Do we have? Okay. Well, let's see when we catch up. Okay, go to the next. I think we may need some darkness in here. See, we're captive to our technologies. really. And okay, next. No, it's not that. Okay, yeah. Okay, next. Next. All right, we talked about that. Next. Okay, and next, there are also other degenerative neurologic diseases that can look a lot like Parkinson's disease in some regards. Things such as cortical Lewy body dementia, calcifications of the basal ganglia. These are, for the most part, uncommon, certainly in relationship to how common Parkinson's disease is. And from a practical point of view, these distinctions are not going to be made in general practice. Okay, next. There are three main neuropsychiatric syndromes within Parkinson's disease. And this is mostly things that have become appreciated in the last 20 or 30 years. Before that, people assumed, like James Parkinson, that this was a physical illness only, that it did not affect mentation or mood. But we now know that cognition is certainly affected by Parkinson's disease, and we'll go into that in some detail. Next. Depression is also very common in Parkinson's disease. And then finally, next, the treatments that we use for Parkinson's disease can also have profound neuropsychiatric effects. Next. We'll start with a consideration of the cognitive changes in Parkinson's disease. Next. How common cognitive changes are depends in part on how you measure them. If all you do is to ask the patient, how's your memory, or ask that person, do you know the date, then you're going to find very few who fail those tests, and you'll think that their cognitive functioning is normal. If you use, well, you got one ahead of me, that's okay. If you use standard brief screening instruments, such as the mini mental state examination, that was mentioned this morning, then you'll pick up many more who have failing scores on that screening test, indicating that there is some cognitive impairment. But if you do much more extensive neuropsychological assessment, the kind that a trained test administrator needs to give and that really require an investment of a lot of time to do this sort of testing, if you do that, though, you find that in at least 90% of patients with Parkinson's disease, there is some significant change in intellectual function. What I mean by significant change is at least one standard deviation below the norm in at least one major area that's being assessed. So in those patients, that may not be as noticeable, but it does indicate that this is a disease process that is affecting how these patients think. Next. Now, when it comes to defining the nature of the cognitive changes in Parkinson's disease, one finds that it is a little bit different than what you see as cognitive impairment in Alzheimer's disease patients. One area that is affected by both Alzheimer's disease and Parkinson's disease is memory, but it's affected differently. A patient with Alzheimer's disease will have great difficulty learning, storing, and retrieving new information. In patients with Parkinson's disease, it's the retrieving step that is most affected. And this is going to be determined when you test a patient, and let's say you give that person 3 words to remember, and then later you ask the patient to recall those words. Well, the patient may start out saying, I don't remember them. But if you give a cue, say, well, one of those words was a color, then they'll say, oh, of course, it was red. And one of those words was a vegetable. And they'll say, well, oh, cabbage. Now that you mention it, it was cabbage, and so on. And so that response to a cue indicates that, in fact, the information was learned and stored, but there's difficulty in retrieving it. And so that pattern is consistent with the kinds of memory changes seen in Parkinson's disease. Next. There's also bradiphrenia, which literally means a slowness of thinking. slowness of movement that Parkinson's patients have is paralleled by this slowness of thinking. A little bit later, when I show you a tape of the patient who's the subject of the case, I think you'll be able to see just how slow the responses are in some cases. It can be very frustrating when you're examining somebody with Parkinson's disease because they're so slow, you want to finish the sentence for them. You want to move on to the next question, and you may assume that in fact they're not able to answer, but what really is required is a little more patience, because very often with a little more time they will be able to come up with the correct answer. Next. There's also impairment in what we call executive functions. These executive functions include complex planning, complex problem solving, ways in which you manipulate knowledge to solve problems. That also can be affected by the Parkinson's disease. And it seems likely that these areas are affected because of the connections between the motor systems of the brain and the frontal lobes, which are responsible for many of these cognitive functions. Okay, the next slide. Just how frequent is dementia in Parkinson's disease? And again, this depends upon how you define dementia. So next, if you use the DSM criteria, and what Dr. Small went over this morning in his definition of dementia comes pretty close to what the DSM criteria are. They emphasize memory impairment. They also tend to emphasize, those criteria emphasize a constellation of findings that fit Alzheimer's disease best. But if you use those criteria and ask the question, how many Parkinson's patients are demented, you come up with about 10%. Next. But if you use a different definition that isn't quite so much linked to the specific features of Alzheimer's disease, if you use the criteria developed by Cummings and Benson, then a figure of 40% dementia is I think, a much more accurate representation of the number of Parkinson's patients who have clinically significant change in their intellectual functioning. And these criteria that I'm talking about, the Cummings and Benson criteria, are change in intellectual function in at least 3 of 5 areas, including speech, language, memory, visual spatial function, and then mood and personality as the 5th area. So one sees that that's a pretty high rate of cognitive impairment. If one uses that milder definition of dementia that begins to look like the 90% cognitive impairment that you would get with neuropsychological testing. Next. There are some features of the disease process that do seem to correlate with the presence of dementia. The age of onset is one of those. Next. And so that patients who get Parkinson's disease over the age of 55 have a higher likelihood of developing dementia than those who develop Parkinson's at a younger age. And although Parkinson's disease is primarily a disease of the elderly, it is not that uncommon in younger patients also. And I've had patients with the onset of the illness in their 30s, for example, so it's not that rare to have an early onset. Next. The presence of dementia also seems to correlate with the duration of the disease. The longer the person has the illness, the more likely they are to become demented. Now, with aging, all of us have a greater likelihood of becoming demented. But in this case, in the Parkinson's patients, the rate that is seen is much more than is seen in the general aging population. So it does seem to be a manifestation of the progression of the disease and not just a manifestation of increasing age. Next. Another proof of that is that the dementia seems to correlate with the severity of the disease, but only if you look at the severity. Maybe we need the lights a little bit down. I see people squinting so they can't read what's on the slide. Is that true? You can't read that slide well? I can't tell. It's fine in front. Is it fine in the back? It's not fine in the back, so we need a little more darkness. Thank you, Nancy. So if you measure the disease severity by the amount of bradykinesia and rigidity, then you get a reasonably good correlation with the dementia. Next. But the tremor itself, that's what that says, okay, less dementia with tremor. So when patients have more tremor and less rigidity, they're less likely to have dementia. Okay. The next. The effect of medications on Parkinson's cognition is also quite variable. So that whether or not these patients are being treated with Sinemet, their cognitive function is relatively unchanged. Okay? Next. What is it that causes dementia in Parkinson's disease? One theory is that it's the coexistence of Alzheimer's disease. Both of these are fairly common illnesses. They will occur together with some high frequency. And when you look at the brains of patients who have Parkinson's dementia, depending on the study, 10 to 50% of those patients seem to have the pathologic markers, the plaques and tangles of Alzheimer's disease. So at least in some cases, we see dementia because they also have Alzheimer's disease. But this is not true in all cases. Next, there are, even in the studies that showed 50% had Alzheimer's disease, 50% of these demented patients did not have the pathologic markers of Alzheimer's disease. And in this case, it really seems to be that a subcortical process, the Parkinson's disease, is affecting the dopamine pathways of the brain, and that has a direct effect on intellectual abilities. Next. In some cases of Parkinson's disease, in addition to the pathology in the substantia nigra, that's the dopamine part of the brain, there is also pathology in the nucleus basalis. And Dr. Cummings showed on his picture of the brain where that nucleus basalis was, but that is a cholinergic system. And even though it is affected in Alzheimer's disease, it is affected in Parkinson's disease in some patients as well, even though they don't have Alzheimer's disease. So when you have that double whammy, both the dopamine systems and the cholinergic systems affected by the Parkinson's disease, then there seems to be an even greater amount of cognitive dysfunction. And then finally, next, there is this condition called diffuse cortical Lewy body disease. This is an illness that's getting attention recently, in part because our way of diagnosing it depends upon some very sophisticated stains that the pathologists use that were not in routine use until very recently. So this may be much more common than people appreciated, and it may be that 20 or 25% of patients that we think have Alzheimer's disease have this cortical Lewy body dementia. Is also the cellular pathology that's seen in Parkinson's disease. So these patients seem to have a combination of cortical problems, as is seen with Alzheimer's patients, and these subcortical patients, as is seen with Parkinson's disease patients, and so it has these overlapping features of Alzheimer's and Parkinson's, and can be misdiagnosed for either. And this probably is contributing to a certain number of patients that we think have dementia with Parkinson's disease. Next slide. Okay, we're going to move to the next part of this topic, which is depression. And depression is also very frequent in Parkinson's disease. Next slide. At some point in the course of the illness, 40 to 60% of patients with Parkinson's disease have major depression. And again, if we go back to what was discussed this morning about major depression, we're really talking about that more severe kind of depression with the multiple symptoms of mood disturbance as well as a lot of physical changes. Now, a lot of people think, well, gee, if I had Parkinson's disease, I'd be depressed too. But in fact, it really doesn't have much to do with the degree of disability. Next. No matter how severe or how mild the motor impairments are, these individuals are at equal risk for getting depression. So it really seems to be a biological phenomenon that's caused by these abnormalities in these chemical systems of the brain. And it's not merely a psychological reaction to having a chronic illness. And I'm not saying that psychological reactions to chronic illness aren't important, but this is not the full explanation for why Parkinson's patients can get so depressed. Next slide. It is also not very related to whether these patients are on treatment or not. If you look at the literature, there's some suggestion that for some people, the starting of treatment with Sinemet, levodopa, may actually precipitate some depression. Others say, well, you know, they actually do a little bit better in terms of mood once they're started on a treatment plan. So it seems to be a wash. Overall, the treatment of the motor symptoms is not related to the depression. Next. In many ways, the clinical features of depression in Parkinson's disease are the same as the clinical features of depression in patients without Parkinson's disease. Next. In both, it's difficult to diagnose, but it's particularly difficult in Parkinson's patients because on the basis of the illness itself, they have many of the physical complaints that patients with idiopathic depression have. These people are slowed down. They will have constipation frequently. They will have a blank facial expression. So you can't just look at the physical symptoms and assume the person is depressed. You actually have to probe their mood more and try and get the feeling dimension of the depression. Next, and then next. One difference between depression in Parkinson's patients and idiopathic is that although suicidal ideation is common with Parkinson's disease, successful completion of suicide is relatively infrequent. And that may just be because these are patients who are physically more dependent and maybe not capable of carrying out a suicide, no matter how much they may wish to. So the fact that it's less lethal doesn't make it less serious. Next. Also, anxiety is a very prominent feature of Parkinson's patients, particularly if they're depressed. And it sometimes comes across as anxiety as a substitute for the feelings of sadness and depression. Next. There are many ways to treat depression in Parkinson's disease, and the thing that they all have in common is that you treat it. Okay? Even though this can be conceived of as a biological depression, okay, the old line of thinking that because it's biological it won't respond to treatment is just false. There's no evidence that depressed Parkinson's patients respond differently to medications or any other treatment than patients who don't have Parkinson's disease. Next. Even though the Parkinson's medications themselves don't treat depression, it is worthwhile to make sure that, in fact, the treatment of the Parkinson's disease is optimized. Then, next, if the depression is of significance in terms of its severity, one would go to the usual kinds of antidepressant medications, and these were discussed this morning. The tricyclic medications have anticholinergic effects, which is a mixed blessing. Anticholinergic effects ameliorate some of the physical symptoms of Parkinson's disease, but it can worsen some of the cognitive effects. So in general, I would still recommend using the serotonin reuptake inhibitors. One thing to keep in mind is that Eldepril, which is another medication used in the treatment of Parkinson's patients, will interact with the SSRIs, so you wouldn't want to prescribe them both at the same time. And then finally, next, electroconvulsive therapy is fairly effective in the treatment of depression in Parkinson's patients and may also have a transient but significant benefit on the movement disorder itself. Okay. Next. I mentioned that the treatment of Parkinson's disease can cause many neuropsychiatric complications. Next, in mild forms, these may take the form of severe nightmares. Next. And then if you continue on the medication, these nightmares then become replaced by hallucinations and some of the delusions that Dr. Cummings talked about even during waking hours. Next. There also can be prominent mood changes, and these mood changes can be of a depressive nature, or commonly a euphoria or mania can be induced by the treatment. Next. But the most common thing is delirium or confusion, acute confusional state. This is the most common neuropsychiatric side effect of the treatment of Parkinson's disease. Next. And I'm using this phrase, treatment of Parkinson's disease, quite generally because it doesn't matter what medication we're using, whether we're using the older anticholinergic medications or Sinemet, which is levodopa, or dopamine agonists like bromocriptine or pergolide. All of these are equally good at causing Parkinson's patients to go crazy. Next. And those patients who are starting out with cognitive problems are more vulnerable to these side effects of the medications. When you have these side effects, you're really in a bind, because if you treat this kind of confusion by lowering the medications, then very often disabling physical symptoms result. On the other hand, if you try and treat these symptoms of confusion or psychosis with neuroleptic medications, you are likely to worsen the Parkinson's disease as well. And this is where clozapine, as Dr. Cummings discussed this morning, may be indicated. It's still a risky medicine because of its side effects, but the clozapine doesn't affect the physical symptoms of Parkinson's as much as these other medications. So when you need to treat these, and it doesn't just respond to changing the dose of medication, that may be the way to go. Next. Okay. Anyway, okay. What I want to do now is take a few minutes and show a videotape of an interview done with this patient who's described in your case. And if those of you who may not have had a chance to read that case can sort of look through it as this video plays. This is a case that of a woman that I started taking care of when I was an intern, and sadly she died a few weeks ago after we put this presentation together. So I think if it's ready, we can run the tape.
I'm sorry. Such thing about having a mood? Oh, I guess that means that either that you're not feeling anything or that things are pretty neutral in the middle. More in the neutral. So you don't feel real happy, but you don't feel real sad either. What about your memory? How's that going? You recognize letters with something. You remember my name? Right. Almost always, I know you do remember my name. Every once in a while when I come visit you, maybe after you've gotten up, or sometimes if you've taken a dose of medicine, every once in a while I think you might forget my name, but almost always you do remember. How would you compare your memory now to say 1 year ago? Not as good. Okay. What I would like to do would be to repeat some of the memory questions that I did ask you last year, and we can compare. Okay? Some of these questions are pretty easy, and I don't want you to be offended by an easy question. Some of the questions are a little tricky, and I don't want you to be worried if you don't get them all correct. All right? And I'm just going to take notes of your answers. Okay? What's today's date? 26th of April. It is a Monday. What year is it? 1993. What season of the year? You're saying it is summer now? Well, it feels like it when it's so warm and sunny out. But what's the season that April is in? Spring. Right. And what place are we at? What's the name of this whole place? VA. Do you know what building you're usually? What building is the nursing home? That's right. And what city are we in? And the county? And the state? All right. Now I'm going to give you 3 words, and I want you to repeat them for me. Because later I'm going to ask you to remember the 3 words. Okay? I want you to remember rose, hat, and carrot. Can you say those for me? We'll come back to those, okay? Rose, hat, carrot. But in the meantime, I would like you to start with the number 100 and count backwards by 7s. Yeah, that's a tough one. Yeah. D6, and keep on. And I heard you say 79. Good. And keep going. 65. Terrific. Terrific. What is this called? And this? What part of my watch is this? The wristband. What part of the band is this? Right here. Can you see that right there? What would you call that? The belt might have one of these also. Buckle, right. I want you to say no ifs, ands, or buts. Good. I'm going to give you a piece of paper. I want you to take it in your right hand, fold it in half, and put it in your lap. Either way. Want me to help you crimp that? Okay. You really want to finish the job, huh? That's good. What was the last step? Do you remember? The last step. I told you to do 3 things. What was the last step? Yes. So can you do that? Excellent. Okay. That's fine. I'm going to write a few words on this piece of paper, and I want you to read them and then do what it says. And I know that since you're a nurse, you can read my handwriting. Can you do what that says? All right, good. Now you can open your eyes. I'm going to give you this paper and a pen. I want to see you write a sentence. Okay? See if you can write a sentence. You want me to hold this, or you want to hold it? Little. Just right in. Here, let me take this piece out of the way so we can just write on the pad. That way. time for all good men in the aid of their country. Okay, it's very legible, although it is very small too, isn't it? I'm going to draw a picture. Now I'd like you to make a copy of that picture. Good. And the last thing I want to ask you is to go back to those 3 words that I wanted you to remember. Can you remember them now? Mm-hmm. Cat, yeah. Carrot. One more. It was a flower. Good. Good. Now, the one other thing that I want to do, Mary, is just see how your muscles are, okay? Can you just let me do the moving? I know this hand has those fingers that are contracted, and I can feel some of that tremor within the muscles as I move. And I can feel it a little bit in this hand too, although the right hand is a little bit looser, and the right arm a little bit looser than the left arm and hand. Can you make a muscle like this for me? Show me how strong you are. Okay, good. You pull strong. That's good. How about on this side? Pull strong. Okay, excellent. Very good strength. Now, if there's anything else that we need to talk about, is there anything that you looking for, Jill?
No, but I know you still enjoy. You have a friend who comes and visits you every week. And you were mentioning that you wanted to buy her a present for Mother's Day. Mm-hmm.
Yes, Mother's Day. Yes.
Oh, she lost her mother.
Yeah, Mother's Day is next week. Okay. Anything else that you would like to tell me, Mary?
Yes, Mr. Senior.
I'm too young to hear it. It's a good note to end on. Maybe after the camera stops, we can flip. Shame on you.
All right. I'm sorry, what? Oh, she never told me. I'm too young. Okay. So I think that, we can see in that tape, although there's a basic intactness to this woman's cognitive function, there's that profound slowness, and at several points you needed a little bit of a reminder or a little bit of a clue to sort of get back on track. One would look at her and it's quite plausible to think that this was somebody depressed because there's no facial expression, she's slowed, and yet towards the end you can see that she still has a sort of lively sense of humor, and actually at the point that this was done was in pretty good spirits and enjoying her life as much as possible, really. Okay, we're going to move on now to our our panelists. And we're going to start with a nursing perspective that's going to be given by Jill Shapira, who is an adult nurse practitioner and clinical nurse specialist at the West Los Angeles VA Medical Center. Jill and I have worked together for many years with patients in the dementia clinics and the neurobehavior clinics. And Jill is now in the middle of her PhD in anthropology.
Thanks, Michael. It was a rather humiliating experience to see myself 3 years ago on that video. As Michael mentioned, am I on for the slides? As Michael mentioned, this person died about a month ago. And I'd just like to take a few minutes and acknowledge how much I appreciate all that she taught me personally, and I think Michael too, and many of us in this room, I noticed, who work with her. I was reminded, just sitting there watching that videotape, of one of my favorite stories. It wasn't too long after we made that film that she needed to be admitted to the acute care facility at Wadsworth for a pneumonia. And I was visiting her in the hospital, sitting in the only chair in the room, and Michael came in to visit her too, to see her, and she said to me, "Get up, a doctor came in." And and I said, "I will not." You know, we had been trained at different times, and she was adamant, and she and I argued, and Michael got the chair and brought another chair in, and the three of us had a conversation. So that was one of my remembrances of Mary. What I thought I'd do is we each have just a few minutes. I thought I'd just say a few general comments about caring for patients with Parkinson's disease in any aspect of a care setting. All of us, healthcare providers, take care of patients in ambulatory care settings, acute care settings, and also in nursing homes. And I had the privilege of working with this patient through all those different settings. So for some general comments, for any patient who has Parkinson's disease, and in the outpatient setting, I hand out a sheet like this for family members and patients when they have some kind of an elective admission, so they're able to be prepared for the hospitalization. One thing, many of these medications that are given for Parkinson's disease are titrated very carefully, and some are given every 2 hours, some every 3 hours, some every 4 hours. And once a patient gets in the hospital, as close as we can keep to their at-home medication regimen, the better it is for them. It's often difficult in a hospital setting when we have our own rules and regulations. But if at least keep the medication as consistent as possible and as close to the time that they get it at home. Also, as we saw from this videotape, these patients can be very slow and need extra time in getting dressed and eating and getting bathed. And if we try to rush them, I don't know if you noticed it, but when Mary was trying to fold the piece of paper in half, her tremor increased. And so give them more time than we would give other patients is something I've learned. I've also learned to try to schedule procedures, if possible, when their best time occurs during the day. For example, Mary, her best time usually was very early in the morning. So one thing we try to do is schedule her elective x-rays, etc., and occupational therapy and physical therapy during the early morning hours. I've also found it helpful to print statements on 3x5 cards for patients to take to the hospital with them. Some of you may have had trouble hearing what Mary was saying. Did you? And she would have difficulty making her needs known if she wanted a drink of water or needed to use the bathroom. So if we had cards for her, we could show her the cards. She could read. We saw that. And she could then communicate with the healthcare team. Eating and food requests are critical areas for Parkinson's patients. It takes longer for them to eat. They have swallowing difficulties often throughout the course of the illness. And we need to find out what types of foods are best tolerated and what they most enjoy. Another thing with this particular patient, she was very embarrassed early in the course of her illness, even about the way she ate. With her tremor and the swallowing difficulty, she often spilled, and you could see some of the drooling that she had even without food in her mouth. In the nursing home care unit, a goal of most nursing homes is to socialize patients, and patients eat together in one room. This caused embarrassment for her, and the team decided to allow her to eat privately in her room, which was helpful. Finally, it's real important, these patients have to keep mobile. So when they're in any kind of a hospital setting, make sure they get up, make sure they ambulate as much as possible, because once they go home, they lose that ability quite rapidly. Michael mentioned the confusion and the delirium that is so common in these patients, primarily because of the medications they're on. Nurses are often the first-line defense to pick up when a behavioral change or a mental status change occurs, and we can alert the rest of the treatment team that we think there's an impending delirium, so adequate evaluation and treatment can be done. And finally, my last general comment is, I think we need to consider the needs of the families and significant others of these patients. If you had a loved one in Mary's condition, leaving her with a staff who couldn't understand her or care for her, you would feel, I think, that you want to be right next to her at all times. Well, these caregivers can be quite elderly too, and I think we need to encourage the caregivers to get the rest they need by making sure we understand what patients are trying to tell us and what they need. Okay, just a few comments related to this specific case. Mary lived the last 10 years, 11 years of her life in the VA nursing home care unit. And this video was taken 3 years ago. You could see how feisty she was, you know, and she still, and from my story that I told you, she still had very strong ideas of who she was and who she wanted to be. Anytime you come into a living situation like a nursing home, sometimes some things have to change. In Mary's case, and I think this is typical of many patients who have chronic diseases with which they've learned to manage, you know, we tell them, focus on your condition, figure out what time your medication should be given to maximize your movement, and then we put them in a living care situation, and the rules need to be changed. Mary reacted to that and was quite focused on getting her medications at exactly the right time. I'm a nurse. I've never gotten my medications out at the right time in my entire nursing career. So this created a lot of friction with the staff. Mary's need to be independent and to manage her own life conflicted with her real needs for care and her need to be in the nursing home, and we're going to talk about how we handle that in the next slide. The other thing that was problematic for nursing staff was this on-off effect. It's described in the case. With Parkinson's patients, you can see that Mary, in the video, she was quite tremulous and had a movement disorder. But 5 minutes later, when I was waiting with her for the VA van to take her back to the nursing home, she became very dyskinetic and choreoathetotic with a lot of movements and with her tongue moving in her mouth. And at those times, many patients become disinhibited with their thoughts and what they say. So she inadvertently would offend some of the nursing staff who was providing care for her. And that, again, created some friction. This on-off effect also was confusing for nursing staff, where 1 minute, her best time, as I said, was early in the morning, 5:30 in the morning. She was up making her bed very early on in the nursing home, doing her hand washing, and at 6:30 she couldn't move. She was completely immobile and would need to ring the nursing staff to move her big toe, literally. Well, the nursing staff had trouble understanding that and felt they were being manipulated. So that was the second area that we worked on together. And finally, as you can see, Mary still had a lot to offer. She had a lot to offer our system. And she was a member of the Nursing Home Council, and so for those things that she, as a nurse and as a patient, wanted changed, she could do. in the Nursing Home Council, and we tried to redirect her energies in that way. Okay, so I've alluded to some of the problems that that are typical when anyone needs to come into a nursing home, I think, someone who is independent. The nurses, at the beginning of Mary's hospitalization in the nursing home, were quite angry with her. They were angry with some of the things she said. They didn't feel appreciated with the care they were giving. And I was asked to come in and do some in-services with the staff. The first several sessions that we did, I just let them talk about how angry they were and how badly they felt. And it wasn't just this one patient, obviously. In any kind of a caregiver situation, this happens. So for 2 sessions, that's what we talked about on all 3 shifts. And then by the 3rd session, we were able to talk about Parkinson's disease in general, and they were able to develop by themselves, to reconceptualize in a way Mary's behavior within the context of her disease. And they were able to then change their feelings about what they were seeing and change their behavior towards her. We weren't able to change her behavior much. Second thing that we did is Dr. Muller listened very carefully to what the nurses were saying. Not only did we want to maximize Mary's movements and the time of day that was best for her, we also wanted to take into consideration the needs of the organization. And we listened to the nursing staff, and he was able to modify her medications to best meet the needs of the organization too. And Mary agreed with that input. So we listened to the nursing staff very carefully and able to negotiate with her what times of day she needed to be most active. After these 3 sessions, the nurses were able to work with her without feelings of anger. She felt good about better about being where she needed to be for care. And let me leave you with this. A little consideration, a little thought for others makes all the difference. I think we need to be considerate of each other as care providers and not assume that we don't have feelings and that they need to be looked at first. Thank you.
Thank you, Jill. Our next panelist is Rosalie Davis-Green, who's going to talk about the social work perspective. And Rosalie is a clinical social worker graduating from St. Louis University School of Social Service. She currently is the supervising social worker for all of the geriatrics and extended care programs at West Los Angeles VA, and is a clinical instructor for social work interns working at USC, UCLA, and Cal State University of Long Beach. So, Rosalie? Oh, there you are. Okay.
I didn't have the pleasure of working directly with Ms. Campbell, but I did know her. And one of the things that this case brings to my mind as I read over her diagnosis and the history of her disease, it became apparent to me that one of the points at which social work could have been involved is at the point at which she began to have increased functional impairment. At that point, she began to have several falls. This was an opportunity to mobilize some community resources to facilitate living independently in the community and maintaining her quality of life. One of the first things to do is to make a thorough assessment. In order that you can develop a care plan that the client will utilize and that the client wants. As care providers, we can come up with wonderful care plans that will provide a variety of resources to clients, but if we don't consider the client themselves, they may not want to even utilize our care plan. So the first thing I really would like to stress is that it's real important not only to find out what are the specifics of the individual's psychosocial situation, but what types of interpersonal social supports does she have? Does she have friends and neighbors? Is she active in community groups? How is this illness affecting her sense of independence, her sense of security, and her sense of self-esteem? How is she dealing emotionally with this loss of function? What is her coping style? How has she dealt with other adversity in her life? What is her understanding of her condition and its anticipated progression? What does she like to do for enjoyment? What makes her life worth living? All these things go into making a good assessment and helping us develop a roadmap to figure out an excellent care plan for the patient. We also have a wide array of community resources that we could bring to bear, tangible things to help her living situation. I'll run through these very quickly. Some of them, I don't think it mentioned in the case, but her income was about $600 a month Social Security retirement. That's not a very high income. As we all know, living in our community, rents are very high, food costs are very high, transportation is high, care services are high. But there might have been some other financial assistances we could have provided. SSI, supplemental security income. There are a couple of case management services that are available in our community that also provide additional income to clients. Plus, they organize a variety of services for the clients, home-delivered meals, counseling services. Maybe some type of home health to monitor her functioning at home. There also are emergency alert services, whereby a client living alone, if she falls and can't get up, has a gimmick that she can wear around her neck, press a button, it'll raise an alarm, and then someone will come and check on her. All these things are excellent. Someone like Mary, who is fiercely independent, and as it says in the case, at the end was scooting up the stairs on her seat, dragging her groceries after her, may not have been willing to accept these kind of services. Then again, maybe these kind of services were not even offered to her. Scooting up the stairs on your seat, dragging your grocery bag sounds horrible to me. But many older clients I've worked with want to do everything themselves as long as they possibly can. Some of them, it does not occur that there's an alternative. Others absolutely refuse to consider any help until they are almost helpless. One of the things I also want to mention about community resources is that community resources are fragmented. We heard this mentioned earlier this morning, and many community resources are funded for specific populations with specific incomes, and only certain programs in certain communities have these resources. So one of the tasks of the social worker is to learn what the local resources are that are available to the client, then to sit down with the client, talk about the needs, the resources, and see what kind of a match will come together that the client is comfortable with. For some people, living at home with as many support services as possible, as long as possible, is the ideal goal. Other clients would much rather go into residential care and assisted living, where many services are provided for them automatically for a monthly fee, and they don't have to worry about organizing all these various services and being sure that the services arrive on time and so forth. These are the kind of things that you only can find out if you really take the time to talk with the client, listen to the client, and learn who the client really is. One of the things that really facilitates assessment is home visits and home evaluation. And even though the clinical interview can provide a lot of information, as Dr. Meller mentioned, sometimes if you go the quick and dirty route and just ask the client to answer questions, you'll get appropriate answers. But if you actually go out into their home situation, you may see terrible disarray, a house that hasn't been cleaned in months, dirty dishes all over the place, no food in the cupboards, broken stairs, 25 stairs when the person can barely walk up 2. These things really also enhance your ability to make reasonable plans for the client and to really evaluate the level of functioning they're at. One of the things that is a big concern to me is that in times when budgets are tight, one of the first things that's eliminated is time to do the home visit. Now, each agency doesn't have to do their own home visit, or each care team. They can access and utilize some of the community resources to do the home visit for them. For example, Visiting Nurse Association offers home visits by social workers to do home assessments, which can be something we at an agency like the VA can utilize to enhance our own clinical assessment and treatment processes. The other area that's really important in this assessment process is including the family and the significant others, if there is family and significant others. In the case of Mary, she was a single individual who lived alone and didn't really have someone involved in her daily care on an ongoing basis. So with her, the main person to work with was just Mary. Once the decision was made for her to go into the nursing home level of care, there are other tasks to be focused on. One is health advanced directives. Now, that could have been addressed earlier, of course, but when we get into the nursing home level of care, it's required to address advanced directives, having health care preferences and decisions prepared, having funeral arrangements made. This is something many of us don't like to do. You certainly don't have to wait till you're disabled or ill to do it. In fact, all of us should have these things in place. Wills, funeral arrangements, healthcare decisions. And how many of us have already done that? I'd like to see a show of hands. Not very many of us. Well, you know, I'm a believer that we ought to practice what we preach. And as you see, my hand didn't go up either. So I'm somewhat of a hypocrite in this regard. Another thing that the social worker can be very valuable with is working with the client around the issues of loss. Each time a person, you know, has a major increase in loss and function, there's an emotional component, emotional reaction to that. It's helpful if the person has an opportunity to talk about that, to have someone listen supportively, to have someone help them look at how can they have choices, how can they continue to enjoy their life even though they have less and less function and maybe can't continue to do some of the things that they used to do. I think Jill covered a number of things that also can be addressed by the healthcare team, including helping the client have choices, in helping the client adjust to the regimen of the institutional setting, helping the client to deal more comfortably with lack of privacy. And I think, last but not least, this can be extremely gratifying work, but it can also be extremely frustrating and aggravating and wearing. And I really feel that as healthcare providers, we all need to nurture ourselves, to be kind to ourselves, to recognize that sometimes this work is tiring and frustrating, and that we don't come up with good solutions. To network with each other, to give ourselves opportunities to go to conferences like this, to live a balanced life and to nurture ourselves in our own lives so that we can bring back to the workplace some enthusiasm and zest for living to communicate with our patients. Thank you.
Okay. Next will be Stacy Wilkins, who is a clinical psychologist with expertise in neuropsychology. Stacy is the psychologist with the GREC at West Los Angeles, and she's an adjunct assistant professor at UCLA in the School of Medicine, Departments of Geriatrics and Gerontology. Dr. Wilkins does research in the areas of depression in the elderly, caregivers of demented patients, and cognitive effects of medical conditions.
Got a couple overheads here. I also didn't have the opportunity to meet this actual patient that Jill and Mike had worked with. But I wanted to speak a little bit from the perspective of sort of working in an interdisciplinary geriatric team and the psychologist's approach, focusing on looking at cognitive assessment and also recommendations for folks. So I'm going to have you move to the next slide if you can. For most of you, probably you have some familiarity with neuropsychological assessment. And I know Mike and other speakers have touched on this. What I did want to list is just a number of the cognitive domains that we actually do assess. And in this Parkinson's patient, in the case, we obviously had someone very high functioning who probably maybe at the very end would have found deficits, but was really quite intact, and I guess had cognitive testing partway through her disease progression and did quite well. But often in the team, there'll be concerns that people aren't doing so well. And so one of our roles is to really look at these different areas of functioning in a very much individualized approach to find out for that specific person what their strengths and weaknesses are to tailor an intervention. Okay, the next slide. What I did want to then highlight is specifically for Parkinson's disease, what are some of the common cognitive and emotional concerns? Again, some of this is a review of what Mike had covered, but clearly dementia is an issue. In the research I was looking at, 35 to 55% of cases, which fit very closely with your 40%, actually can be diagnosed with the dementia syndrome. So it is a significant concern to be alerted to. Cardinal features often are memory loss. Typically, it's more the forgetfulness where the person benefits from reminders. In the videotape, I think the patient was able to recall 2 of the 3 words, and then once Mike had said it was a flower, she could remember the 3rd word. So it's that kind of forgetfulness and benefiting from cueing. Also, studies have found visuospatial skills, especially constructions, seem to be impaired, often in Parkinson's, that may be somewhat linked up with the executive deficits, but clearly is another area where patients often have difficulty. Executive functions, as Mike had mentioned, but it's things like difficulty with problem solving, especially kind of more abstract or new problems. When someone, for example, in this case, moves to the nursing home and she was presented with a new novel situations or difficulties, she's likely to have more trouble than someone who wouldn't have executive functions. She didn't have executive function problems, but if the patient did. Also dealing with shifting sets, sustaining attention, and also fluency can be reduced. It's difficult for these patients, if they have executive problems, to do more than one thing at once. A good example of that is if you're trying to talk on the telephone and someone's talking to you, if you have children, you're very familiar with this phenomena. But patients with executive problems have real trouble doing two things at once like that. And then fourth, obviously, motor slowing is a significant problem that you see quite often in Parkinson's folks. And then just to mention that the depression does occur in 40 to 60% of patients across the course of the illness, and it's critical to treat and responds very well to treatment with medication, as well as Rosalie had said, really providing the psychotherapy and just adjustment. It's a chronic illness, and people often have adjustment to loss over time. On our team, we kind of shift between psychology and social work in terms of who provides the therapy. I know nursing often does in other settings too. Okay, the next slide. Now I just wanted to recommend or talk about some treatment recommendations. So we've tested somebody and find they have deficits. I think it's important. The purpose of doing testing is to improve the patient's quality of life. If we just know they have deficits, it doesn't help them much. So if we find patients have memory problems, which is very common with Parkinson's, using basic things like calendars, memory aids, literally having them in the room, having places where the patient can even be, if possible, responsible for, say, marking off days, having some control over that, writing things down, placing remainder objects in a prominent place. It's a classic thing. I think someone earlier this morning mentioned about losing your keys and misplacing objects. If you always have one place where things go, that's a classic strategy that's helpful in terms of remembering things and using established locations. So again, for a patient who's having memory difficulties, the more you can have their world organized and have things where they can find them. Also, presentation of tasks one step at a time. You don't want them to you forget the fourth task. I know sometimes nurses who aren't maybe aware on our unit of a patient's difficulty come in and say, okay, I want you to brush your teeth and then go to the bathroom and shave and then come back and have your breakfast. And the poor patient, if they have significant memory loss, maybe gets to the sink and gets totally confused about what they're doing. So to really simplify to one task at a time. And it's key to have education of caregivers regarding limitations. I know in our team we try and really give helpful feedback to our team and also through family meetings to the families about limitations the patient may have cognitively. And next slide. And then finally, just to mention, often executive functions are compromised in Parkinson's patients. And just some things that are very helpful, structure and routine. This is helpful across the board with executive functions. From children with ADD tend to have those kind of problems. And what you do in this classroom is you put them by themselves with no distractions. Again, if Parkinson's folks are having those difficulties to structure their environment, kind of have each day be similar if that's possible. In institutions, sometimes that's easier, sometimes not. Also simplifying new tasks, breaking it down into steps, kind of doable pieces. You want to set up an environment that guarantees success and doesn't allow the person to fail and feel overwhelmed. And then finally, eliminating distractions. You don't want to give, for example, in occupational therapy, a new task to a Parkinson's person in a room where they're having some other, say it's rec therapy, throwing balls or something behind them. It's going to be much more difficult for them to then focus and concentrate. So those are just some kind of simple, basic recommendations, but often make a great difference in quality of life and capacity to function independently for our patients. So that was just the brief highlight. I don't know, I guess if there's time, we'll have a question and answer panel. Thank you.
Thank you, Stacy. Our next speaker is Dr. Robert Wang, who trained in medicine at the West Los Angeles VA Medical Center, and then went on to complete a fellowship in geriatric medicine in the UCLA VA program. Unlike those of us who were chicken and stayed at the VA, Bob struck out on his own and helped to develop what was a very innovative program, particularly 10 years ago when he started it, the Center of Geriatric Health at Century City Hospital. He is also the president of the Pacific Providers Medical Group, and Bob is going to talk about the organizational and financial considerations for the community care of chronically ill and frail elderly patients.
Thank you. As Mike said, this morning when I talked and listened to Dr. Cummings and Dr. Norman, Mike, and Steve, particularly Steve Reed, his dulcet tones I used to listen to into the odd hours when he was at Century City a lifetime ago, discussing some of the esoteric fine points of diagnosis and treatment. But the truth is that I spend probably by a huge amount, I spend the majority of my time not looking at those fine points of treatment and diagnosis of patients, but rather figuring out how to get my patients the care that they need. Because as some of the other speakers have said, care is very fragmented in the community. And so I'm going to talk about that a little bit. We've only got a few minutes, so basically I'm only going to touch the highlights. But I think it's important that any of you, whether you're in the VA system or you're outside, have to step back when you're taking care of frail elderly patients like Mary and figure out, how do I put myself in a position so that I'm in an organization that really allows me to take care of these people. As you all know, go ahead, geriatric patients have multiple reasons why they're difficult to take care of. There are multiple physicians, multiple medications. Go ahead, just. They have mobility limitations. Next. There are multiple therapeutic modalities involved, medical and psychiatric comorbidities, cognitive deficits, again. They need assistance in ADLs. They need appropriate social and entertainment activities. They have financial limitations. They have chronic illness with progressive debilitation. There are issues of institutionalization. And there are stereotypical preconceptions about these people. And then finally, some of the hardest things to deal with, I find, are dysfunctional family support and unrealistic expectations. Okay? I think that's enough problems. There are probably several dozen more. Obviously, this kind of situation requires complex multidisciplinary approach. So how do you go about doing that? The ideal would be that form follows function. I mean, you've all heard that expression. In the ideal, a system develops the way it should in order to get things done. What's the reality of the situation? Function follows financing. Okay? We do what we get paid for. That's what we all do. And that's how we end up taking care of these patients. Next. I don't know if you can see this. This is just to give you a conceptual idea. What our healthcare system is like right now is a disjointed patchwork of organizations. And I've just put up two organizational charts for the hell of it. The one on the left-hand side is the hospital. Hospital CEO at the top, and it goes down. Next one is the doctor's office. And obviously there's a skilled nursing facility, there's a home health agency, there's a physical therapy firm, et cetera, et cetera, et cetera. Each one of them has their own bottom line. And each one of them are going to function, especially in today's medical environment, to get that bottom line where it needs to be. Not to communicate with the other, not to take over responsibilities of the other organization. Okay. Next. In addition, we've got a problem of culture clash. And I know that I heard that we're approximately divided, 1/4 physicians, 1/4 nurses, 1/4 social workers, 1/4 psychologists. MDs look at the problem and they say, I want to diagnose and treat this patient. Okay. Nurses want to implement that and provide care directly at the bedside. Social workers want to advocate for the patient. By the way, anybody who wants to be offended can be offended. These are my own shorthands. And therapists want to retrieve function. And by therapist, I'm using the whole gamut of therapies. Okay. Oftentimes, and I don't know how much you all appreciate, especially those of you at the VA, because I think the environment's a little bit different there. But certainly in the community, even if I sat down with somebody in a different discipline, what I said, the words I used, would be completely different from the words of the other discipline. And we might not understand each other. So what we regularly do at the Center for Geriatric Health in Century City is we abuse the social workers and they abuse us right back. And so we understand each other. Next. Okay. So, in this kind of setting, what are the incentives in a fee-for-service healthcare world? Narrow the focus of services to maximize income. Okay? If you're running one of these organizations and it's your job to make it run, you don't do anything extraneous. You do what you have to do, you get out. You limit unreimbursed services, such as interdisciplinary communication. Go on. There's repetitive collection of data when it's reimbursed. If I do an EKG, so does the cardiologist, so does the pulmonologist, so does everybody else, because they all get paid 25 bucks for it. There's election of well-reimbursed therapeutic modalities. If a little bit of one-on-one psychotherapy can do it, but a psychiatric hospitalization can do it and make more money, there's a bias. Go ahead. There's a compartmentalization. Since the psychiatry bottom line is different from the medicine bottom line, there are two different departments. And things don't get, communication is not good between those departments. And then oftentimes, one concern is that therapy gets done regardless of prognosis. Nobody steps back and looks at the entire patient. You just go ahead and do the therapy. That's what you get paid for. Okay. Next slide. You avoid unreimbursed social issues. Because again, nobody pays for that. It's somebody else's problem. And when there's a social problem or a family problem, you often medicalize it, meaning you put them in the hospital. You know, the daughter can't take care of the patient. The problem is that the daughter has to figure out what to do with the patient. Instead, we just put them in the hospital. Okay, so now we have a bright new world of managed care. Are we going to do better there? Well, let's look at what I think the current status is. Obviously, the goal of managed care is to minimize overall cost to the system. So we'd like to do that. But what is happening right now, as far as I can tell? With the current structures, what's happening is the health plans are contracting with individual providers and passing the risk through to those providers. In other words, if you're a doctor, they give you a set amount of money, and then they say, take care of the patient regardless of what happens to the patient. That's all you get. And so as a result, each provider then is put in the position of having to minimize their own costs, because their profit comes out of minimizing their own cost while getting the fixed reimbursement. So far in managed care, as far as I can tell, all we've done is make it even more clear that each provider organization is not going to think about other people, other providers, and communicate with them. They're trying to maximize their own profit. In some cases now, it's basically, it's a case of survival. They have to do that in order to financially survive. Okay? Now, it may be that in the future, as managed care organizations mature, and you can figure out how to communicate within between the various providers, you will in fact be able to develop systems that give you better organized care. But I don't think that's the case right now. The ideal situation would be what we would call product line management and budgeting. And I'm very impressed because I saw that the VA has been have been using these very words and has, in fact, been advertising for people at central office to go ahead and really develop product lines, and that's amazing to me, but all the better. In a product line kind of environment, what you would decide is that you had a specific type of service to deliver, like geriatrics. And the management would come through a geriatric service manager, which would coordinate hospital services, outpatient services, doctor office services, SNF services, et cetera, et cetera. And if this person had control of the budget, they could in fact allocate the money where it would be used best. All right? This is, as they say, this is like a Radisson hotel organization. When you come into the Radisson, you don't negotiate for a maid to clean your room, for somebody else to clean the shower, for somebody else to clean the pool, somebody else to drive your car up. You get the whole package. You say, I want a room and I want service. You get the whole thing. That's product line. Okay? Next. Okay, so just summarizing, what are the practical implications? In order to provide comprehensive geriatric care, form must follow function. And I can't give you the details because each of us works in a different type of organization. But basically, what we really need to do is to figure out within each of our own organizations, how do we tie these services together, and how do we really make it work by having it budgeted and structured in such a way that the services get tied together. That's my comment.